We're going to talk about all the major injectables out there, even some ones that we talked about yesterday, silicone, but more focused on exactly what problems can occur in inexperienced hands and how to fix that. The first one I think most of you use are the hyaluronic acids, and we're going to talk about how to avoid complications. As you heard yesterday, the allergic reaction has gone down a lot since they purified some of the antigens in the late 90s. And the great thing about it is that you can actually reverse all of this with hyaluronidase. I'm going to tell you how to do that. I use really blunt cannulas now for the entire face with Tulip. I call it the laminator, but actually I don't make any money off them. I refused any honoraria from them as well. My practice is converted entirely to a hyaluronic acid-based practice. I've moved from using all different types of products just down to this. Just so much easier. Also, because I run a practice that's primarily fat grafting, I'm able to convert over to fat grafting easy by dissolving this. So people always talk about dissolving it, but how much do you put in? And I want to just make a practical guide for you guys based on my experience. You want to be careful. You can put a little bit of Vitreous in, the whole hyaluronic acid just goes away. So what I found out is, this is, again, these are what I've done. I don't want to give you the wrong numbers, but this is what I've been doing, and I found if you need a small correction, very, very little, 0.05 is about, 0.01 is probably too small, about 0.05, and occasionally 0.1. And if you just want the whole thing to go away, I put in like 0.4, 0.5 of the Vitreous. And that works really well. Always start small and go up. That's my feeling. And I have never had to nick the skin. I just like dissolving it. But if it's really close to the skin, theoretically, you can just nick it, let it extravasate. Calcium hydroxyapatite, I think, is a great product, but there are a lot of things with it that you have to be careful with. What I found in particular, we saw some advanced techniques of nasojugal groove in injections. I and also talking to some of my colleagues across the United States have had issues with prolonged and idiopathic erythema in the area around the tear trough. So be very careful if you're an inexperienced injector. I don't know what causes that. I don't put anything near the eyes with Radiesse. When I did it in combination with RESTYLANE around the eyes, and I did Radiesse into the cheeks and jawline. Just don't do it in the lips. If you're getting great success, I'm not here to tell you otherwise. There's many ways to skin a cat, but in my opinion, I wouldn't do it. The labial-mandibular fold is an area that's a bit tricky as well. I've had one patient where I had a hand piecemeal remove the product, and the reason for that is there's a very small distance between the mucosa and the skin. When you're injecting into the labial-mandibular fold, my suggestion is at the end of it, no matter what product you use, just take one finger and feel in there. Make sure there isn't a lump. If there's a lump, you want to just gently massage with one finger, not two, because you're going to squeeze it out of the area, and that usually just one little push will get it right into position. I like cheek injections with Radiesse, but I had some problems early on. What I do to avoid this is an intraoral technique. I'm going to show you that in just a second here. And the nasolabial fold is nice. Obviously, if you've got that kind of stiletto nasolabial fold, it's going to be harder to fill. Sometimes you sit there and you put 2 or 3 vials and you get no change. So obviously you want to make sure that you pre-select your patients carefully. This is the intraoral technique with Radiesse. I've actually stopped doing intraoral techniques because I don't do Radiesse anymore, but it's a great product in my opinion. I don't have any affiliation with any of these companies. The reason I like the transoral technique, I'm filling the malar septum. Now for the nasolabial fold, you go transcutaneous. But when I'm doing the malar septum, I've found that there can be a lump if you don't do it really perfectly and precisely, and get a lot of bruising with this. What I do is I target. You don't want to just spread your injectable products everywhere. You want to target maximal areas so the patients get maximal benefit with minimal syringes. And when I hit that malar septum, that's where I target that anterior cheek, that linear threading. And, linear defect. I go in a scaffold technique with it going up toward the skin without hitting the dermis and just going up and down. I found that lattice work, even though you're working to fill a linear defect, you don't see any lumpiness or linearity when you go through the mouth. This is after a nerve block, by the way. Managing complications of calcium hydroxyapatite, you shouldn't get them. Here's a thing that I'm going to be really adamant about, and for the experienced injector out there that's doing this and not having problems, great, but for people just starting with Radiesse, please don't go intradermal. I mean, don't do deep dermis. The company, I've heard, even company policies, I've talked to the president, I think you're going to get into a lot of problems doing deep dermis if you're just starting out. If you've done 100 of them and you have no problems, and I'm not here to tell you to change, but I would really advocate a subcutaneous injection. It's very hard to control this product in the deep dermis. Here's some of my results. This is Radiesse into the cheek, and this is JUVEDERM under the eyes. I really haven't seen the complications under the eyes, but given all my colleagues' complaints, I stopped doing it, and I just do RESTYLANE around the eyes. And so this is Radiesse. It's 1 syringe of Radiesse in the cheeks jawline, 1 JUVEDERM syringe per eye, and 1 extra I think I use JUVEDERM as well around the lips, and I don't really do the nasal. I don't do nasolabial folds for 80–90% of my practice. I do really volume fills. This is a lady that I did lower eyelids with RESTYLANE and then cheeks, jawline with RADIESSE. That's 1 syringe of RADIESSE and 1 of RESTYLANE per eye. And this is all done, the RADIESSE was done with a needle. This is an older technique I did last year, and the RESTYLANE was done with my cannula technique. This is Perlane and RESTYLANE. It's 1 syringe of RESTYLANE per lower eyelid and Perlane into the cheeks and jawline. It's 2 Perlanes, 1 into the cheeks, malar septum, focusing on that. If you don't know what the malar septum is, it's that linear depression that goes diagonally across your mid-cheek. And then RESTYLANE, 1 syringe of RESTYLANE per eye, and then 1 syringe of Perlane into the jawline. And this is not all cannulas. This is all cannulas. This is Perlane. Again, 1 syringe into each cheek and 1 syringe into the jawline, and then 1 RESTYLANE per lower eyelid. Here's the thing, if you look at her, you can actually see maybe the nasolabial fold is deeper, but does it matter if she looks this good? But you've got to pre-consult the patient. If you're doing volume contours and avoiding the nasolabial fold, with the highlights that you create in the cheek, you can worsen the fold in the nasolabial area. Now, of course, you could expend another syringe. In my opinion, it's not worth it because I don't really care about the nasolabial fold. I convince my patients through these photographs that volume contouring is really the ticket. Polylactic acid, I stopped using it. I don't think it's a bad product. In my hands, it's too expensive. It takes too long to get a result. Patients that come in for fillers, they want the result yesterday. I think a lot of this stuff has now been modified already. I'm not going to dwell too much upon it, but just make sure you use an adequate dilution, that you dilute the night before. I don't want to get into these textbook things, and do the careful massage, and obviously avoid areas that can be real problems like the lips and the nose and other places that are unpredictable. Liquid silicone, I think, is an interesting topic, as probably most of you don't do it. You've heard some great techniques yesterday. Today I want to focus both on great technique as well as how to address complications that can occur. Take your time, fill a little bit at a time, and not be aggressive. If a patient comes back at 2 weeks, they have to go home. It's 1 month minimum time between each session so that they have plenty of time for that to become walled off by fibrosis and collagen. This is a very aggressive treatment. This is 5 treatments of silicone, 0.3 to 0.4 per session over a period of about 7–8 months. And this is 2 treatments of silicone. And you can really see the key is that, you want to design a lip. A lot of people just inflate a lip. And this is that little bit of a cleft in the bottom. You heard about some of the aesthetics of lips. I really challenge you to understand the aesthetics of lips before you start just injecting them, blowing them up. The bottom lip, as you see, is a cornerstone to really be able to make a gorgeous looking lip without overdoing it. And this is all silicone, very, very soft. Please be careful with silicone. Obviously, if you're not an experienced injector, you shouldn't be doing this. This is completely off-label. I think that's been clear yesterday, but in case you were in the meetings yesterday, it is completely off-label. It is used for intraocular injections right now for retinal detachments. The biggest mistake I see is even with RESTYLANE, my God, is that everyone injects the upper lip too big. You need to focus on the bottom lip, no matter what the patient comes in for. The upper lip is a big mistake because it doesn't look good blown up. And I'm going to show you some problems and how to correct that by balancing it. Here's a lady that had this done in Colombia, and you can actually see the upper lip is lumpy, bumpy, and way too big. I actually did I can't remember actually, 1 or 2 lip reductions of the upper lip. Still not much shape to it, but the white lip is also inflated, which looks terrible. And I didn't want to go try to recontour that upper lip. I think sometimes discretion is a better part of valor. And the lower lip is done with 2 treatments of silicone of my own to build that lip in continuity and balance with the upper lip. And you're going to see all these mistakes where the upper lip was overinflated and done poorly. So this is an excision on the lateral aspects of the upper lip and then inflating the bottom lip with my own silicone, creating that heart-shaped lower lip and creating some balance between the 2. Again, and this is actually the opposite. This is too much shape to a lip, and it's also still imbalanced. So I unified the bottom lip and made it a little bit closer so there's not so much of a gap, and did a little bit of contour shaping to the upper lip without making it become too big. I wanted to actually create balance between the 2. This is, I actually don't remember what this woman had in the upper lip, but you can see it looks almost like a ledge. So I softened the 2 little holes there with silicone, then I built the bottom lip up with 2 sessions to create more balance between the 2. So I thank you for your attention this morning.